Healthcare and senior care is fraught with problems and challenges, but we're also seeing some amazing new clinical treatments and resources. This show will help illuminate and uncover the good, bad, the ugly in order to equip patients, families, and other healthcare providers. Welcome to Senior Care Confidential.
So, Joe, we have been teaching a class, Leslie and I. We have Leslie with us today. Thanks for joining us.
Thanks, Leslie. Glad you're here.
Join.
So we have been teaching a class about a subject that you and I discussed months ago after my grandmother's passing. And we were discussing this thing that I had just never heard the term of, this cascade of dependency thing. And the more and more I studied on it, the more we started to realize, holy smokes, like we just don't know these things in the medical field. Obviously, clearly, because it's in papers, like there's interesting research and there's biochemical changes and cellular changes that happen because of this immobility. But we're not really taught this stuff like in schools. And so now that we've actually been going and doing these presentations, like the educational seminars for some rehab hospitals and hospitals, I'm realizing how little we actually understand on the actual impact of immobility. And so I guess one of the big, one of the big takeaways that I've learned is I think a lot of times, and probably because a lot of times we see PTs as like the exercise guys, right? Or the exercise gals. And so, obviously we're there for functional mobility and we're there for safety and those kind of things. But we see muscle, I think, largely just as a structural thing that helps us to move. When you think of, I don't want to get weak, usually it has something to do with your function. Like I want to be able to move like I want to be able to move. I want to be able to play with grandkids or my kids, or I want to play soccer twice a week or whatever. And so we see muscle in almost in a very isolated context of it's just for movement. And one of the things that I realized, actually there's several things I realized, but one of the big takeaways is muscle is far more than just movement. It's actually a safeguard to health. Because just by the mere fact that you have, we'll use the term cross-sectional size, but essentially muscle girth or muscle mass. If you have muscle mass and you're actually causing those muscles to contract and relax against resistance, so lifting something or pushing something or whatever, there's actually cellular things that happen at the body, within the body that actually help protect you from other things. Like it affects your immune system. We'll go through some of these things today, but one of the big ahas for me was how much the muscle strength aspect impacts so many other body systems. And if you've been around me for long enough, I'm on this like mitochondrial kick. Leslie always makes fun of me every time we do this, but so the mitochondria thing is like a huge thing, right? It's the battery powers for your cells. It allows you to move. It allows you to stay alive. Like it fuels everything. But within that, like the muscle strength piece seems to be a large component of mitochondrial health. And so when you start going like these deep dives, and it's fun, it's been really fun to teach this to nurses and doctors and physical therapists and OTs and STs in these rehab contexts and hospitals, because they're like light bulbs are going off everywhere. Like I've always known that immobility is bad, but not necessarily to the extent of what they get taught by us. And so I felt like maybe today would be a good opportunity to kind of revisit the conversation we had earlier this year about my grandmother's death, now that I'm a little bit less raw about it, and kind of go through a little more of a deeper dive on what is actually happening deeper than what we can see just through, they're getting weaker because they're laying in bed and they can't move around as much. There's so many things that are happening downstream from that. You've ever heard of the term maelstrom? Maelstrom.
I mean, it feels familiar.
Me too.
Okay, you ever seen like a pirate movie, like Pirates of the Caribbean, and they're fighting and they're going around this like vortex, and the vortex is like pulling them under the water? You know what I'm talking about? So that's essentially what this is. Like that cascaded dependency. I hate the term cascaded dependency, by the way. If you ever want to do like a deeper dive, like research on it, you have to use that term because that's like what's been accepted. We're gonna fetch is gonna happen. So we are gonna change this term because the term sucks. The cascaded dependency does not reflect nearly, I don't know how to say this. The impact of it does not get reflected in that term cascaded dependency. It is so much more than that. And so like maelstrom, if you get that visual picture in your head where by the mere fact that we have this immobility happening, all these other systems, these multi-systems are feeding off of the immobility, which in turn, by the way, it creates this positive feedback loop where, because we're affecting these other systems, those other systems then impact immobility again. And so it's this crazy accelerated dive down into the bottom of this maelstrom, this whirlpool. And so that's probably like the best way to describe like what you're seeing, because it's not, the problem with cascaded dependency is it implies like a domino effect. Like, one thing causes the next, causes the next, causes the next. It's not that, because those dominoes are not then in turn coming back and affecting the root cause, which is what's happening here. Right. And so I think understanding that it's like a doom loop that's happening to our bodies. And that's probably a great way to describe that. We hear about doom loops in financials or whatever. This is a doom loop that's happening at the body level, or at the body level, and the multi-system level, all because of immobility. And so I thought we would go through a few things, just probably not all systems, but like some really key ones that I think would be helpful. And I think your perspective from like doing these talks with these rehabs in hospitals is virtually the same, right? The responses we're getting.
You're giving, you're naming what it is that we're experiencing, but we keep it siloed like you talk about, right? But then to say, oh, no, they're all related.
It's a great way to put, because you being a nurse and me being a PT, we talk a lot about the dangers in healthcare systems, and both of you guys are nurses, in being in siloed functions, right? So I'm a nurse and I do these things, and my Practice Act says I get to do these things, and I'm a PT and I get to do these things because that's what Practice Act says. And I think when we start to look at immobility strictly through the functional side of things or the strength side of things, it gets pushed to PT. And what we're going to learn today is, like there's a lot more that has to happen here, because it actually affects nursical stuff, if that's a word, and physician stuff, and all these other things, and dietary stuff. And and you mentioned the name. So the name, I hate the name cascaded dependency. So we are retitling this thing Hospital Acquired Frailty. Hospital Acquired Frailty.
And that is,
it describes it.
It describes
right?
it.
And one of the things that I recognize is, if you look at any congressional bill or whatever, like the name of something really is important. It doesn't, now in our world, like we're actually going to make it mean what it actually means. But we're not writing a congressional bill that says something that does something completely opposite of what the bill is called. But it goes to show you how much marketing goes into naming something. I think cascaded dependency does this a disservice, and it does not, the flashing alarm bells do not go off when you just think of, cascaded dependency. That sounds so nice. Like, no, it's hospital acquired frailty. And so, there's all these, initiatives is probably the right word. There's probably a stronger word from that, but there's things that are happening from like the regulatory level where they say, if you get hospital acquired pneumonia or a hospital acquired infection or whatever, then, because there's like 7 or 8 of them last time I looked, of these hospital acquired whatevers that are like I wouldn't call them a red flag system, but it's something that's being counted.
Oh, yeah.
Right. And so my thinking is, well, shoot, if we just call it something hospital acquired, then it will force people to actually to pay attention to this. But I still think somewhere in there, like the doom loop or the maelstrom has to be in there, but we'll figure that out. But for right now, our working title for this is hospital acquired frailty. By the way, for the audience, hospital acquired frailty can absolutely happen at home. We're just calling it hospital acquired frailty to help make a bigger, impact.
It's usually where the biggest experience is to start that doom loop.
Yeah, because usually if you go in the hospital, right? It's like, Joe, you work with a bunch of people. There's usually something bad that's happened to you that sent you to the hospital. So we all understand that as we have older aging bodies, our ability to come back from some of these things is it's harder, right? There's it's just a natural function of being older. And so for these particular patients who are going into a hospital system, the infections happened, or, a UTI or an exacerbation of CHF or a fall or whatever. So something bad's already happened where the body's already under distress. And then you combine hospital acquired frailty to this, and it just spins out of control. And so, getting to them at that point is really crucial, but we still see immobility and its effects at the home site too. That's a lot of what our focus is within Nexus. But, I know both you guys have worked on nursing floors before, so you guys have seen this like firsthand. And Joe, so I know Joe, you called it when you were a baby nurse.
When you were a baby nurse,
yeah.
So
it was different.
It was totally different. We had a nurse's aide that helped us on the floor, certified, and we didn't. The thought of I'm going to wait till PT comes in, unless they were over 500 pounds. You know, we did it.
Yep.
If the order said get them up 3 times a day, we got them up 3 times a day. I would go get the aid and say, we're doing it now. You know, breakfast is coming in a minute. So we didn't pass it on to somebody else, is what I'm saying.
Yeah, it was widely recognized that immobility back. And the crazy thing is, it's still recognized now. But because we've had, and we can go through, in fact, we'll do it now. I think there's some reason, when we first talked about this, back before I did a deeper dive on this, we had talked about, I don't blame the nurses, the doctors, or the therapists. I think it's a systemic issue. And my thinking was, it's probably some regulatory stuff or whatever. I did a post on this a couple weeks back, and it's got almost like 500,000 views now, and hundreds of shares and comments. Where I got DMs from doctors all over the world, which has really been amazing. I'm now gotten connected with Johns Hopkins, by the way. Johns Hopkins has an ambulatory, I think it's called ambulatory mobility program, the AMP. I think that's what it's called. Anyway, one of the head guys there, he's a PT. He and I have gotten connected over this. And so it's been fascinating because I've gotten to learn some things, because I don't work acute care. It's been a very, very long time. But I choose to believe that nurses, therapists, and doctors love people, and that we're not intentionally leaving people to suffer in their bed, right? And so I think there's a lot of things that happen. So one of the things he pointed out was, because there's been such a huge focus, because I think there's financial penalties, if I'm not mistaken, for falls. I believe there is. And so because there's a huge focus, we've got committees in the hospital focused on all these initiatives. And one of those committees is focused on falls. So it's a second and third and fourth order consequences we don't consider when we enact policies sometimes. And they're probably quick starts like I am. And so they're just not thinking like, hey, this sounds like a great idea. So what are they doing to avoid falls? Well, they just leave them in bed. It gets worse. Anyone who has the slightest semblance of a balance issue or a weakness issue gets a band that says they're a fall risk. And what happens with people with fall risk? Now, all of a sudden, they're not getting up on their own anymore. We won't let them, even though, and they just actually, Johns Hopkins actually did a study on this, and I'm going to misquote the statistic, but it'll be in the ballpark of the number I'm going to give you. It was something like 3 times as less likely if they're tagged as a moderate to high fall risk to get up, even though that they were mobile.
Well,
like these are people that were mobile, that were not really a high risk, and their issue was it's highly sensitive, but it's not. It captures too broad of a base, and so now you have to push the button every time you're trying to get up. And so some of our own policies are actually creating some of these issues. Go ahead.
Well, and as a care manager, I have a client that was in rehab and was only getting 30 minutes a day, and he wanted to get well. He wanted to get stronger, so he wanted to walk the halls, and he would get up and have his walker and start walking, and they would send him back to his room.
Yeah.
And he was like, how can I rehab if I have to sit in my room?
Correct.
And it doesn't make any sense.
Yep.
It's the fear, right? I was always fearful of getting someone up. I would go into patients' rooms, and even though they were alert and oriented, if they started to get out of that bed, I was like, whoa, let's call your nurse. Like, I don't know if you can get up. Well, shouldn't they be in charge of that? But because of... just purely speaking of the amount of paperwork that it takes in a hospital if a patient falls.
Oh, yeah.
It's an hour or more, depending on the system, on top of the end of your day charting.
But the thing is, what's the point of a high risk? They're a high risk for falls. So we know that.
Right. What I'm saying is they're tagging anybody who's even like a moderate risk or mild risk for falling. These people are ambulatory, and they're getting this armband that limits their ability to get them up during the day. It creates more roadblocks.
So I know when I was at Parkland, we had nurses' aides, we had techs, always had techs, and we'd have maybe 12 patients, and I'd have 2 techs, 1 for 6, 1 for 6. And now I see in hospitals, you don't really see the techs anymore. I will on like an ortho floor. I know UT Southwestern, I've been on floors where they have only male techs. And I get that, for strength, just getting them up. But it's just changed on the floor.
It's a lot on
what it used to be.
Yeah. There's so many check boxes with paperwork and things like that I don't know. It depends on what your prioritization is. Like, what's pushed right now is meds on time, vital signs, lab work to get it cooking, things like that. So if I'm prioritizing that, how am I prioritizing getting the patient up?
They're not understanding what's happening at a much deeper level, because even though we were all taught immobility is bad and it probably affects some of these other systems, whatever, they don't really fully understand what's happening down to the cellular level, because otherwise they would realize, oh my gosh, this actually helps our patients heal, because from what I understand is that there is a benefit in getting patients, financial benefit in getting patients moving out of a hospital faster. And so this would help them. And so this is one of the things that Johns Hopkins is working on. So they've got a program for it that they're trying to get pushed out that will help with some of this stuff. But it's a cultural change that's required at the hospital level. But
I think with our seniors too, it's a cultural change.
Oh, for sure.
Because they used to be told to lay in the bed for the whole time that you were there, and you would be there for 2 weeks for something that we're discharging you the next day.
I think it's a staffing thing too, since
COVID. It's all things.
Well, and you think about from the seniors' perspective, think about we're all younger. Some of us had recent birthdays, but some of us are younger still. And so when we're young and we're healthy and we're tired, what do? That's our signal to go rest, right? We're going to take a nap. We're going to get, if I just got like a good night's sleep, I'll wake up completely refreshed tomorrow, right? So for our first, 40, 50, 60 years or beyond, that's kind of our programming of I'm tired, so I rest and I get my energy level back. Well, when you're older, it doesn't work that way. It does, but it doesn't. And so what ends up happening is they get stuck in this loop of I'm tired. I remember when I was younger, this has always worked. I take a nap or I rest longer. I just lay on the couch or lay in a recliner for a while and I'll get my energy level back. What ends up happening though is because they're older and their body doesn't respond quickly the same way, they're actually getting weaker with the rest. And so now they're in this loop of I'm tired, so I'm going to rest more. Because I rest more, I'm weaker. I'm becoming more immobile, right? So I need to rest more because I'm tired, and on and on and on.
Or even
it goes.
Family members.
Yeah.
I mean, I used to, as a case manager, when I would assess a patient, depending on, the situation, I would suggest home health just to have a coach.
Yes.
To get you up and moving, because I wasn't sure that they would push their loved one enough to get moving.
And muscle mass or muscle strength is a safeguard to health. And I can't impress upon people enough. You hear me, even like in our fall prevention classes, like I hammer this home because it is so crucial. There's a doctor, you guys can look her up. I think I heard she's on TikTok now, but everybody's on TikTok. I'm not on TikTok, but everybody's on TikTok. Her name is Dr. Gabrielle Lyon, Lyon, and she is a physician who has a strong belief based on her interpretation of the research and data. I tend to believe her that muscle strength is like the biggest thing that you can do for health and longevity, and not just because we can move, because of other effects of it. So we'll go through a couple body systems real quick, just so you can kind of understand like how deep this thing goes. Obviously, the easiest thing that everyone pays attention to is the atrophy, right? We're getting weaker as we lie still, but the atrophy kind of goes beyond that. What most people don't understand is there's actually multiple types of muscle fiber depending on what the use is and what the energy source is. And so, what they have found is with patients who are immobilized, they actually start to lose type 2 fibers. They atrophy faster. Well, the problem with that is those are like your movement fibers. You want to know why transfers become difficult? Is because you're atrophying those fibers faster than the other ones. So it's actually specific to fibers that you actually need to work. So it's wild how that works. And then the other thing they find with immobility specific to the muscle strength loss is it's not just that you're losing the strength, if you will, because, we all associate larger muscles with more strength, right? So smaller muscles weaker. So the atrophy is certainly a part of it. But what else is happening is it's not just that the size is shrinking of your muscle. It's that, and there's some statistics. Be really careful with this. They're as high as 5% a day. I think that's specific to ICU patients, but I've seen it as low as like 2 to 3% per week. Somewhere in that range is how fast you're losing your muscle size. But that's just the muscle size. That's only part of it. What they've also found is they think in the first 2 weeks, I shouldn't say they think, let's say current working theory, because there's research that shows this. So our current working theory, because I hate evidence-based practices, that term, that's a thing of mine. But anyway, our current working theory is that in those first 2 weeks, the muscle strength loss is actually because of the nerve connection to the muscle fiber itself. So they call that the neuromuscular junction, right? Where the nerve cell innervates the actual muscle fibers and muscle cells. And so in a normal functioning body, it's like a telephone, or like a conversation, right? I can talk to you and I can hear you at the same time. We call that like duplex, or in our world, we call it afferent and efferent, but it doesn't matter. The communication has to go both ways, right? And so you got communication from the nerve cell to the muscle cell, right? But you also have the muscle cell back to the nerve cell. And those two things have to happen for a normally functioning neuromuscular junction. Well, what happens when you stop moving your muscle? You start to lose the communication from the muscle fiber or the muscle cell back to the nerve, and you start to see degradation there. So some of our muscle strength loss is actually neuromuscular and not just muscle size loss.
Wow.
It's really, really interesting.
Yeah.
And then it does, my favorite subject, it also affects mitochondria. We'll save that one. That's such a deeper dive on that one. And so that's kind of how it starts, right? So if we think of, I hate the word cascade, but if we think of we're going to call it the doom loop. If we think of the doom loop or the maelstrom, it starts with some root cause, right? And so the root cause of all this stuff is actually the immobility. Okay, so that's the root cause, but it spreads like a virus. It doesn't just knock over the next domino, right? And so we start with immobility, and that creates certain things. And so one of the effects is the atrophy or the muscle strength loss. Another effect is actually immune system, which is really fascinating when you really start to dig into this stuff. What happens is when you stop contracting your muscles, you start to lose the number of leukocytes, T cells, and B cells. If you guys remember, for like anatomy and infection, COVID, whatever, those things are part of our immune system to help track down where the infection is and go kill it, right? And so if we're limiting our body's responses because of that, because we're becoming more immobile, now all of a sudden we're actually susceptible for more infections because we can't fight them, all because we're not moving. Because the muscle fibers and the muscle contractions actually help promote leukocytes and T cells and B cells running around the system to try to look for stuff. It also, keeping along with the immune system, it creates a low grade, there's things called cytokines, but it creates a low grade systemic inflammation in the body. We stop moving, you stop having healthy functioning of the muscles, and we get this low grade systemic inflammation. Well, if you think of it, our bodies we have limited resources, right? So it's the food it's the vitamin D, it's whatever, but we have limited resources. And so the body's not about to expend stuff where it doesn't need it, right? And so if you're already fighting a low grade systemic infection everywhere, the next time a new infection, because guess what? I don't know about you, but like sick people go to hospitals. So I'm exposed to bugs that I might not normally be exposed to outside, right? So now I got this low-grade inflammation because I'm not moving around as much. So my body's having to fight the low-grade inflammation at the same time try to fight a new infection. And this is why you see infections go up in hospitals.
Why you see UTIs.
Well, the UTI is a whole different one, right? Because I'm not moving, my bladder is becoming deconditioned, and that atrophies. And so when that atrophies, you end up causing urinary retention. Urinary retention backs up into the kidneys and causes renal calculi or kidney stones, and also bladder infections or kidney infections. Again, all caused from immobility. Yeah, I'll go one further. There's a term called Wolff's Law. I don't know if we've talked about it on the show before or not, but Wolff's Law is specific to bone. But the concept is still applicable across all of your tissues in your body. Like your body, Wolff's Law essentially says your body responds to demands that are placed on it. But Wolff's Law is specific to bone tissue. So in a normal context, what's happening, or in a normal context, in a normal functioning body, what's happening is you have a couple different types of cells. You've got osteoclasts and osteoblasts. We don't really have to get into all the details on that, but essentially you have a destruction crew and you have a construction crew. So just like a house, you're being remodeled every day. And so normally they're operating at an even level. Okay. So you're tearing down the bone tissue as quickly as you're building it back up. Okay. When you're immobile, though, because now the stimulus is gone, the construction crew starts to lose the amount of activity. And so now you're actually tearing down muscle. The body's resorbing bone at a faster clip than it can actually repair it or add more. And so what's in bone? Calcium. So now you got calcium running around your bloodstream now, hitting your kidneys, causing more issues with kidney stones. And what's another common reason for getting patients up or moving, or TED hose?
Well, the blood clots.
Yeah, clots.
Well, now I've got more calcium running in my bloodstream because I'm not getting up and moving around, and my bone is being reabsorbed, throwing more calcium into my bloodstream, which creates more issues for clots. So you see how it's all these things. And there's also cognition issues, right? And so, by the way, one of the things we should be really careful of in hospitals, but also in assisted livings, your body, your brain needs stimulus. It needs just for cognition. In the absence of a stimulus, it's going to get weaker, right? It's like neuroplasticity. You're going to lose some functions if there's a lack of sensory. And I see in a lot of places, like even in some assisted livings, I will have to go put my patients' hearing aids in.
I know. Are there glasses
if they can't
on?
hear, exactly right. If they can't hear or see, we're going to negatively impact their brain. Also happens in a hospital. So make sure that, first thing in the morning, we're getting your hearing aids in and eyeglasses on.
I'm pretty sure we tell them to take the hearing aids home, because if it gets lost
in the hospital, not in assisted living.
In the hospital.
Even in the hospital. See, but again, but we're creating,
not always, right?
But we're creating this cognition issue simply because of that. And so there's all these things that happen.
They get lost. They go get lost on the trays.
I get that. You guys, the smarter people than I can figure out how to not lose hearing aids in a hospital. I'm just telling you, if you go through sensory deprivation like they are, I can't hear and I can't see very well, you're gonna exacerbate this cognitive issue. And the other thing that happens, remember we talked about that low-grade systemic inflammation that's happening because of not moving around. Did you know we have this blood-brain barrier for the brain? Like it doesn't allow for certain things to get up into the brain, except for inflammation. So when you create low-grade systemic inflammation, those inflammatory markers actually go up into the brain and cause delirium. By the way, it's not dementia. Don't give my patients a new diagnosis of dementia 24 or 48 hours after being in the hospital. It is not dementia. We're not putting them on meds. And for the family members, you probably don't need to be looking at memory care. If it's a sudden onset or a sudden worsening because they've been in a hospital, it's called delirium, and it's fixable in most cases. Some cases not, but we don't need to slap a new diagnosis on it. It's because all these other things are happening that are making things worse. Yeah.
You and I have talked about bringing in a picture from home, because it's so powerful with your grandmother. Bringing a picture from home and hanging it right over the patient's bed so that the providers that are coming in, and this is literally our only view of that patient, right? That we can see, this is not our baseline.
Part of the reason why that a LinkedIn post took off was because I did a before and after, and I showed her 2 weeks. I showed her 2 weeks later, and when I was talking with my parents as this was going on, they couldn't get an ear of somebody who, it's not that they didn't care. They're busy with their job. They got 6 other patients or 20 other patients or whatever. And so you see this little old lady who's shriveling in front of your very eyes, and they just assume, well, she's 94. Of course she's old. And this is what happens. She's just old. And my mom finally got her phone out and stuck her phone in a picture of my grandmother 2 weeks prior to in front of the doctor's face. He went, holy crap, this is different.
Right.
Like, no kidding. We've been trying to tell you this for now a week. And so I think sometimes the lack of a feedback loop, to your point, like not having a picture of, hey, this is what my mom or my dad looked like a week ago or 2 weeks ago. We're getting them in a hospital environment after something bad's already happened, and they're already experiencing this hospital acquired frailty, right? The doom loop. And so because the doom loop can happen, by the way, you can see blood pressure changes and cognitive changes within a day. It is that fast.
And bed sores can develop within a week.
Yeah. And how likely is it? How much pushback does a therapist get when a patient's already having some cognitive decline when we're trying to get you out of bed? Like, quick. And so they're seeing this, a day or 2 days later, these nurses and these doctors like, yeah, of course, she's kind of towards the end.
In the hospital.
We probably should, prepare the family, or, maybe we get hospice involved and blah, blah, blah. And so that's kind of what this is. But I think that's a great point to actually, hey, here's a picture of what my mom looked like a week ago. Right? That's a huge, because it reframes what we're seeing.
Well, and remembering that this is our perspective in the hospital setting, all we see are sick people.
Correct.
And so it's not like we imagine them being well and walking around. We can only deal with what's in front of us. So I think part of it too is that respect for the profession, that we're looking at the doctors and nurses and leaning on them.
Oh yeah.
And
you mean as the patient? We're kind of deferring
or as
to the
family
expert.
even to say, oh, well, I guess she has had a little bit of memory issues before she came in.
You brought up a great point when we were talking about this a couple weeks ago. You'd mentioned something about an impression of certain patients, because they're seen lying in bed and they look really frail, that they're probably not appropriate for PT.
Yeah.
And which is a really interesting thing, because because I understand, like, you see a patient, they look really weak, and you're like, they just need to rest and get a little stronger, and it doesn't work.
Just even dementia alone, I worked at an amazing hospital. Like, we worked as an interdisciplinary team, so we all were on the lookout for each other. Like, we overlaid, right? Yeah. But it doesn't work that way everywhere. Everyone has their blinders on because they have so much to do. Yep. But even dementia, I mean, we would get demented patients up, but unless we really advocated for it, we were being told by our expert physical therapist at times that the patient wasn't appropriate because
they don't remember
it. But you've also talked about how there's layman's term, muscle memory, and that if we continue to get them up, I mean, they have to be willing.
There's always a risk. So you have to balance the risk of, where I'm coming, I had this patient who changed my life forever. Now, again, it's a one-off patient. I get it. Don't DM me and say that was one patient. I get it. But this is an extreme example. I had this patient who was, pretty severe Alzheimer's. She was only like 90 something pounds. She was tiny. This is back in Florida. She was living in a residential care home, and her doctor had asked me to come help her and see what I could do because she was getting to be a lot for the caregiver. She was a max assist ×2 and she was 90 pounds. Like, she just was it was hard for them because she was just a ragdoll. And so I worked with her on trying to reestablish her memory on how movements actually work with the body. Because I figured she's got 90 years of practice with this. She hasn't been this bad for this long. Like, she only got this bad within like the last few months or whatever. So let's just see. And so by the time I was 6 weeks into it, she was already a minimal assist with one person. And one of the last times I saw her, she actually looked up into my eyes, which she never did. She always looked down. And so when I had her standing with me, she actually looked up. And so like there was something still there. And that movement actually helped to restore some of that engaging, the eyeball engage. I get it. It's one patient. But still we use muscle memory all the time because your body's used to certain things. It's done for decades and decades. And so you can still make some improvement. But even on the dementia stuff for the therapist in the hospital though, it's because, and I get it. I'm a therapist. We focus a lot on the functional stuff. And in truth, I didn't know all this stuff prior to this year either. But I think when we start to realize how much of an impact physical therapists for sure, but just healthcare practitioners in general, with a focus on restoring mobility, or just getting somebody up and moving them around, or getting them up and sitting up for a couple hours for meals. Those things have such a restorative effect on immune, cognition, urinary tract, pressure sores, all these other things that are happening that we're seeing live time in the hospital. I think we're missing the mark. And some of that, it might just be, I don't know if there's a regulatory thing with that. I don't know if it's a reimbursement thing. Like it might be a hard sell to say, hey, we're going to work on transfer training to help with her immune system. I can show you research that shows that, but I think the payer sources might be like, well, you're doing what?
I mean,
I don't know. I don't know if that's a block.
I always told my patients, research tells me the sooner I can move you out of the hospital and into a rehab, you will have better outcomes.
Well, and
I didn't know what that meant.
I know, and there are good rehabs, and they're really bad in rehabs. So people need to do their homework.
Yes.
But I had a client when I had Acapella, my home care agency. He was in Baltimore, Maryland, in rehab. He wasn't walking. He was incontinent. He was confused. He had been in the hospital. I think it was a cardiac thing. But we flew him to Dallas and we started him on a program, and it was a nurse's aide. It was not a physical therapist. It was not, even a skilled home health that he was getting. But we got him to where he was continent again. He was even walking. And it took probably 4 months.
Yeah.
But, and steps. It wasn't, he wasn't running a marathon, but was using a walker. So you're right, but you've got to work with them. You can't just assume.
Well, and I think too, maybe even thinking about, there were lots of times that I had to teach family members that are younger without a walker, right? And this is their first parent that's getting older and having to be hospitalized, that just sitting on the side of the bed was a lot, right?
Yeah.
That was a good goal for the day, and that it counted.
Correct.
That they didn't have to be running the hallways, to be
so let me
doing
explain
rehab.
one last thing before we close up the show. That has a lot to do with the pulmonary function. So you have respiratory muscles that help you with inhaling and exhaling. Okay. And so when you are supine in a bed, face up. So when you're face up in a bed, even lying on your side, if you're lying down in a bed, let's just say it that way, or even reclined in a bed, the mere fact that you're not fighting gravity and you're not sitting up straight actually diminishes your respiratory muscles. So they atrophy just like everything else does. So what is happening is you find that you will have, because of that, you have what they call reduced tidal, TIDAL, tidal volume. So reduced respiratory capacity. So they'll be out of breath, like you said, laying there sometimes, or just sitting on the edge of the bed, like, oh, man, this is a lot. It's because they're already starting to recognize there's already atrophying happening, including at those respiratory muscles for that. Which, by the way, when that stuff starts to happen, now you're more exposed for secretions and pneumonias, because you can't get the stuff out because you don't have the force to cough it. I don't want to cough the mic, but yeah. So anyway.
Yeah.
So as a PT, how would you strengthen those muscles if you are weak?
Well, first, I think there's a variety of different factors that go into this. I would say the number one priority to start with now is what we're doing right now, which is educating on, hey, we're not going to call this a stupid cascaded depends anymore. We're actually going to call it what it is. We're going to do a lot of education, a lot of hospitals to help at least make sure that we're highlighting this is a real thing. So I think when clinicians see like the data and all the stuff that we've done, they're like, holy crap, I had no idea it went that deep. And so that's great, because you start to change people's practices when you change their framework that they operate in, right? So I think that's number one. And then number two, follow closely behind that, I think it's almost more just prevention. Because it's not a matter of, once they're going down that doom loop, like, you're going to have to work a lot harder to get them pulled out of it. And so there's some really smart stuff that some doctors have informed me on, and some hospitals, like Johns Hopkins is doing some stuff. But they start really early. One of the things that I really like is they do a mobility goal per day. So, most of these rooms have a whiteboard of some sort. Says, hey, my nurse is Keely, she's going to be here for the morning or whatever. Here's your doctor's number or whatever. And so on that board, they'll actually write a mobility goal. Well, for some people, the mobility goal might just be, hey, let's get them up for meals 3 times a day, right? The next day it might be, hey, we need to take 10 steps, right? But they're always advancing that mobility goal. So everyone on the care plan is aware, hey, there is a mobility goal, not because we want them to walk 10 stinking feet. It's because we want to avoid the doom loop of the hospital-acquired frailty.
Well, it makes it part of anything that you're doing, because your meds are right there. It's part of your intervention.
That's right. So there's some really smart, and we can do another show like on some things that I've learned from some of these doctors in these hospitals. It's fascinating. Like it's really fun to have that kind of collaboration, because it's not being done in mass. Like I'm in hospitals every week.
Well, I had a doctor say in a lecture that I heard that for every day you're in the hospital, it's a week of recovery.
Yeah, it's incredible.
It is incredible. So you can't expect, Rome wasn't built in a day. Right. You can't expect to be where you were last week.
It's the the prevention part of it is going to be some of it, right? If we can prevent the escalation of hospital acquired frailty, I think that goes a long way, and that's kind of what our point is with some of these classes that we're teaching, and then we'll get into some other things too, and then making sure downstream from the hospital, from the rehab hospital, even down into the home health, be really selective on the groups that you use that understand therapists are really important, but not just because of the exercise guys. There's a whole host of health factors that happen because we're getting mom or dad up and moving again and setting them up with a home program. And, we've created tip sheets for our patients now based on all of this kind of stuff, just to kind of help with some compliance stuff. But, be selective on who you're utilizing downstream from you too. Because, the hospitals only have them for a handful of days.
Yeah.
And so, making sure, I heard it again today on sniff care from some therapists that worked at this hospital I was at today, that they saw a dramatic cut in therapy time from 2020, essentially, when PDPM came in. And so several of them have left the sniff world to go work in a hospital because they didn't feel like it was doing enough. Now I'll tell you that I work with several here in the Dallas area that I really like. They do a great job. But the majority of them, you just need to really be selective, making sure that they understand. Or
hire an advocate to make sure they're doing what they're supposed to do.
Yeah. That's right.
That's where
true.
I step in a lot is in rehabs.
Yeah. And having somebody there who can vouch for you on I tried to do that through my parents. It wasn't enough, unfortunately.
I know.
And so I think having somebody live can be certainly helpful, to make sure that we can avoid some of these things. So
Thank you, Brian.
All right,
this was
awesome.
great information.
Yeah. Great.